So I want to welcome everyone to the third installment of the Brain Tumor Awareness Month seminars. Again, this is a program for the benefit of patients and caregivers, as well as their providers, and increasing brain tumor awareness. And the focus of this meeting tonight is really showing our patients and their caregivers what really goes on in the OR, because there's so much of it shrouded behind the closed door. And it really doesn't need to be a mystery. We've got some wonderful tools and some techniques which really make brain surgery safer and faster. So I'm Dr. Michael Lemole. I'm a neurosurgeon in the Jefferson system up at Abington. And of course, I'm joined by Dr. James Evans and Chris Farrell and Dave Bray from the Skull Base and Tumor program. And what we're going to do today is go through sort of the steps that we take every time we come into the OR with a brain tumor case or a cranial case, from the moment we put a patient on the bed, secure the head, and move forward with all the interesting tools we have to make things faster and safer. So with that, we'll start with the first thing we do. Now, when a patient comes in, we have to lock their head into a position to make it safe.
Yeah, hold it.
We don't want them moving at all or twitching while we're deep in the brain. And so, although it looks somewhat medieval, and you can see the slide there, these clamp devices that we literally hold to the skull, actually the patients are asleep and they don't really complain of it afterwards. So if we can switch to the live video, you can actually see on a model exactly how that clamp might work.
All right, great. So here we have one of our OR beds that can move in any direction we need it to move. We've got a sort of what we call a sawbone here to demonstrate. These are called the Mayfield head clamps. And basically, as Dr. Lemole said, we don't want the head to move at all. So we need it fixed in space. So first step in surgery is we come in and basically are going to set the head in place, adjust it in, and get it fixed. And this is going to keep the head where we want it and allow us to do some of our fancier stuff with image guidance we'll talk about in a second.
And so one of the important things, like Dr. Farrell said there, just is that this is the starting point going forward. So when we talk about things like our navigation, our GPS, all that is based on that head not moving. Really important. So really important first step. One of the first things you learn as a neurosurgery resident, how to pin the head safely so it stays in place. So now you're ready to get going with the case. And typically at the next step, we would then clip whatever little bit of hair or part the hair we might need to make our incision. And then we start to bring in all the big instruments. So I'm going to go ahead and switch to the slide deck again. And we'll start talking about the various instruments we would bring in. So one thing that's important to understand is that most neurosurgery, particularly brain surgery, is microsurgery. We need to operate with more than just our glasses. And so what we've typically used over the years are these very, very big contraptions or microscopes. And you can see on the slide deck what those look like. The one I'm showing you there is almost like the Cadillac of microscopes. It's huge. It weighs several hundred pounds. But it can magnify what we see 10 or 12 times, and it gives us 3D vision. And we can move in and out. We can have it track with our head as we move. It can autofocus. So that's a traditional microscope, and those have been around for decades. What we're going to show you next, though, however, is the next generation. The microscopes, if you notice in that picture, are always between the surgeon and the operation. You're looking through a physical glass lens to the operation. The exciting thing coming down the pike, some of these exo and endoscopes are putting you closer to the action. So can we shift, go ahead and shift, actually keep it on that. And I'm going to go to the next slide. We're going to go ahead and talk about something called an exoscope. Now, right here next to me, and you'll see it in a second, is an exoscope. An exoscope is, imagine a video camera mounted to a robotic arm that, instead of going between you and the patient, moves around to give you a 3D view because you're wearing polarized glasses, but at the same time gives you as detailed and magnified as view as necessary, but can give you multiple angles without requiring you to move your head and twist your neck and all the things that the traditional microscopes we found can contribute to fatigue in the case. Can you hit the forward button one more time? And so this is the view that a surgeon working with an exoscope has. It's a big screen, usually a 55 or 42-inch screen. Usually, when you're wearing the polarized lenses, everything there is crystal clear in stereoscopic vision. So can we switch to the demonstration now?
Okay, so this is the exoscope. So again, this is a device I don't have to look through, and you can't see it in the room, but we have multiple screens. So like you may see one behind me in a second, right behind Dr. Lemole. This is a screen. I've got another one on the other side. You can't quite see it's off camera, but I can look at. So it's very ergonomic. We'll have 3D glasses on so that everything's done in 3D as well. But this will be able to follow us along now without my hands needing to move it. You can see if I just step on this, it'll kind of follow my pointer along and show whatever I'm looking at the given time. You can see this device is moving behind me without my having to move it with my hands. So that's kind of very helpful. The other thing is it's voice activated. And so I can put this on and I can just talk to this thing. Okay, Vimo. Okay, Vimo. Focus 20%. Okay, Vimo. Zoom 20%. And it'll follow along what we're seeing. I'll step here. It'll come along and follow my pointer wherever I go. It'll focus wherever I point. And it'll be voice activated so it can track what I'm doing without my hands needing to do it. Okay, Vimo. Okay, Vimo. Focus 60%. Zoom 60%. And you'll see it'll kind of zoom in at whatever particular place we're looking. Okay, Vimo. Zoom 20%. And you see it's focused almost immediately. If I step over here, it'll kind of show us around the corner to where this little cartoon of an aneurysm is. Okay, Vimo. Zoom 60%. And it'll come right into whatever we're working on. And then I can get it to, and it'll kind of move along and follow wherever I'm showing with this pointer. So again, very much hands-free, very spontaneous, focusing, spontaneous zooming, and often voice activated. So I can do this at my hands free to work or do my task while this thing follows me along and listens to my voice.
Yeah, and one of the things, and I think that's really important to understand, when we're operating in these cases, we're using both hands. And so anything that takes our hands out to reposition a microscope or reposition a scope distracts us. And this kind of technology is a huge step forward. So can we switch back to the slide deck? So now we're going to move to some different technologies that give us visualization. We first talked about the microscope, then we talked about the exoscope, and now we're going to talk about the endoscope. An exoscope is something that looks from the outside in. An endoscope is something that looks from the inside in, if you will. So the next slide here. So here's an example of an endoscope. Basically on your left side, there's a picture of a brain with a scope going down to the deep fluid spaces of the brain. And that's called a ventriculoscope. But we're going to focus right now on something called an endonasal endoscope. So when you think about the skull and think about your nasal space, it's actually filled with air. And if you follow those air chambers up, they actually get you to the base of the skull. And here's the relationship of the brain to that nasal space. And you can imagine bringing in an endoscope. And as a result, you can get right up close to critical areas where we find tumors. You won't have to pull on the brain or the blood vessels or the nerves to get to some of those tumors. And it's really a game changer. But it's only made possible by having scopes that are high definition endoscopes that we can put right up the nose with our ENT colleagues. And so here we're going to give you some examples of the views those give. Can you switch us back?
Great. So, Dr. Lemole talked a little bit about visualization. I think everything we do in neurosurgery, we're trying to work through as minimally invasive approach as we can. We're trying to disrupt the normal brain tissue as little as we possibly can. So, people always ask me, why does brain tumor surgery take so long? Well, it's usually my wife asking me that question, but most of the time what happens is we're taking out something that's relatively big through a very tiny opening. And we don't have the luxury like they do in the abdomen of moving things aside. We have to preserve all of that. So one of the ways we do that is by using endoscopes and other instruments to visualize what we need to see through small openings. So if there was, for example, you could show our our pepper here that's going to act like a brain. So one of the ways, if we need to get something out from inside, one of the ways is to sort of pop the top, to do what we call a craniotomy and remove part of it. And there we have access and we can see inside. And that gives us a pretty good view, but you potentially can disrupt things. For certain areas of the brain, we can also approach these things through what's called an endoscope. And these are sort of small cameras with unbelievable optics. And we can make a tiny little opening at the base. If you see that little opening, you know, smaller than a dime, and we can actually see things incredibly. So I'm going to advance this endoscope. Dr. Evans here is going to be our assistant, and this is often a two-person job. And he's going to show how we can work through these little openings with some special instruments that, you know, some of which he's helped design that can rotate and work very effectively in these small openings. So do you want to demonstrate some of the instruments before we put them in?
Sure, can you see that okay? These are just little single shaft instruments we use to work in small spaces. Chris said about the size of a dime. If you look at these openings, they're probably just a few millimeters across. They're tiny. And so we need small instruments that can work inside that have the ability to open and close and do these kind of maneuvers where we can rotate them and work around corners through a very small space and through a very small opening. So we'll show that in a second.
So here, and now if you could focus on our screen, and we'd be looking, all of this would be done as we're working, looking at the screens here. So as we advance our endoscope into that opening, you can see we have an amazing view, you know, through this tiny opening, and we can actually work very effectively. So now Dr. Evans is going to introduce an instrument and see if we've never done this before. So
but you can see the instrument can work in this tiny little space that upright. Can work in this tiny little space. I think it's rotate a little bit. But we can work up to where these little seeds are located, and we can, you know, these are tiny, as you know. If you look at this in the gross eye, we get this little tiny instrument working in that little space to a tiny little opening without the need for a large craniotomy.
And we can see these things amazing. You know, we can work around and drive through areas, you know, very effectively and not disrupt things. And again, if we wanted to remove all of these seeds, you could come and take them out one by one. That's where the 6 hours comes from.
And one of the things I think that's important to underscore here is that just like the microscope surgery, this is also microsurgery. Very common for the neurosurgeon to have two hands holding those instruments, two instruments, and their ENT colleague holding that endoscope. So really you actually have three instruments, or sometimes even four up the nose, or whatever small hole you place to get into the place you need to go. So really it's not that much different from the microscope, sort of just taken to the next level by this new technology. Can you switch us back to the slide deck? Okay, next one. So we're not going to show you this in the OR because this is in a different OR, but oftentimes as we're setting up for that navigation, or even during the case, if we want to see where we are, we have what's called real-time imaging. And the examples you see on your screen there are essentially mini CAT scans that can wheel into the OR and scan ahead. And sometimes our colleagues who do spine surgery do it for the spine as well, but basically can scan the head. And we can use that CAT scan information for a couple things. We can use it to make our GPS guidance more accurate. And we'll talk about that in just a second. Or we can use it to check about how much of the tumor we've taken out or how much of the bone we've drilled away to know how much closer we need to get. So I won't belabor these points because we don't have a demonstration, but really important to understand that we have tools to actually update the CAT scans in real time in the OR. And that really can, again, speed things up and make them safer. Can you go next slide, please? We also have another tool here that we're not going to show you because it operates in the background. But believe it or not, when we're operating on the brain, we actually have electrical wires going to the scalp that are measuring the electrical signals from the brain to the muscles and from the nerves and the skin back to the brain. That's called physiologic monitoring. And why that's so important is when we're operating near those areas that are critically serving those roles that move your muscles or give you sensation, we want to know if we're getting too close. And this is our great early warning system. And a lot of times we'll use these on cases because it'll tell us we need to back off or know what's coming up around the corner. So that's called electrophysiologic monitoring, really important tool we use. Next slide, please. Now, this next part we're going to talk a little bit about. It's called neuronavigation. It's a big word, but the bottom line is it's like GPS for the brain. How many of you go driving without your Apple Maps or your Google Maps or your Waze? Almost no one does it anymore, right? We see the world from the bird's eye view of the street and we see ourselves moving on it. Well, our GPS, and you see a lot of cameras in here, it's a lot like that. Imagine that this camera is the satellite talking to your phone, telling your phone where it is on the map. Well, we do the same thing in the brain. We figure out where the brain is in space with this camera, and then put it on the map of your MRI or CAT scan that we got before the case. And then we can literally take a pointer, as you'll see in this example here, touch it to the physical skull or even brain, and it will show us where that pointer is on the virtual skull or brain on the MRI or CAT scan that we've already seen. Really important, especially as you get magnified deep, deep in the brain to know exactly where you are. And again, this is a game changer. This probably came into prominence about 20 to 30 years ago. And really, it's considered sort of a standard of care for any kind of deep neurologic brain surgery. So we'll give some examples now. Can we switch to the... Nope. Yep, there you go. And Dr. Judy has joined us.
So that is registered on this.
Yeah. This is good.
All right, so this navigation device, there are many companies that make them. They came out back 100 years ago, like Dr. Lemole said. When I was a resident in the late 80s, we beta tested these. But this is a game changer because now we can see where we are at any point in space in reference to the patient's MRI scan. Before, we would have to make big holes in the skull to try to find objects. But now, once the patient's registered, is this?
No,
This isn't set up. With this device, we can touch the outside of the skull and see where we are. We can touch the inside of the skull and see, touch the brain. This device comes in a sterile version, which we can use to go down and find that aneurysm that Dr. Evans showed you earlier. Although we're tumor surgeons, we're typically looking for tumors. And also, you've seen brains that have wrinkles in them. And so we exploit that, and we can go down deep into the brain by following some of these wrinkles without damaging any brain. And that's how we get there, by using this navigation device. This takes us down to where the tumor is, and also shows us the normal structures that we want to avoid around it. So this helps us, we combine this with what's called functional MRI scan, where we have actual images of your strength areas, what we call your motor strip, your language areas, your vision areas. And we can use these navigation tools to find them, avoid them, and get the tumor out, actually sometimes even working around a corner to avoid damaging what we call eloquent structures in the brain.
And one of the things that's exciting is that this technology can be paired with all the other stuff we've talked about. So there are exoscopes and microscopes that actually eliminate the need for that pointer. So now wherever we're focused, deep down in the tumor, that's our pointer, our virtual pointer, and we simply have to look up and we see exactly where we're looking. So again, it's integration across all these devices that makes the surgery faster and safer and more effective. So can we go back to the slide deck? Yeah, are there any questions, or should we wait till the end? No questions. Okay. And we can address the list of questions, I guess, at the very end. So if we could go back to was this the previous? All right. So the next tools we want to talk about are how we get in the skull. We've talked about some cool ways of visualizing when we finally get there, or tracking ourselves with a GPS or navigation. But how do we actually get into the skull? I mean, it's a pretty hard noggin. And you can imagine, I got a picture up there of how the ancient Incans used to get into the skull. And that wasn't exactly a pleasant experience for the patient or for the doctor. But we've come a long way. We now have high-speed drills, electric drills that spin tens of thousands of times a minute. And we can actually etch away the bone, or we can side cut the bone to drill it out. And so what I'm going to have my colleagues do here is show you on an actual skull model exactly how that works.
Okay, so here is our skull and this,
You might need to switch.
this is where we want to turn our craniotomy. It's already been made for us.
Move this out of the way. Sure. So we can see it a little better. Go the light there.
But we'll just pretend that it hasn't been made. And we take this tool called a perforator. And what this is just a straight on drill bit, but it's actually a two-part bit in that there's an inner drill bit with an outer connection. So that patients frequently ask, well, how do you get into my skull? And so we use this to make a hole in your skull simply by punching it straight down. And you can see there's, well, that never happens in real life. But it makes us a nice round hole here. And when you're pressing, the inner bit locks into the outer bit. But when you go through the inside of the skull, the inner bit drops down, releases a clutch that jams the mechanism. So that's why we can just keep pressing and pressing, and we do not plunge into the brain. We do not damage the brain. This will only go so far. It has an automatic stop on it. And then once we have that hole, we have this other bit that is a round saw bit with a back rudder on it. We call this the foot plate. Can you see that? And this goes in the hole, hooks right under the edge of the skull, and then we just zip around. And that's how we, oh, so we can take some off. So you go in the hole and take off the skull like that. And then we bolt it back in place with these little titanium plates and screws. The skull itself is does not have much bone marrow, so it takes a long time to fuse, especially in adults. Adults take 6 to 12 months to fuse, whereas children are a lot faster. So we now have evolved to these fancy titanium plates, and we have these little titanium screws, and you just bolt it back into place so that in these little holes on the outside of the plate, we put screws in the bone flap and then in the skull. And that will bolt it in very nicely.
It's important to understand that these will not set off the metal detector at an airport, and you can have an MRI afterwards.
Yes. And these plates, these two plates don't have enough metal in them to make a wedding band, a small wedding band, because they're very thin, but titanium is very strong and it's not magnetic. So that's why we use it.
Can you go back to the slide deck? We also have a whole bunch of other drill bits. Some of them are even finer, and you can literally etch away. There are parts of the space of the skull that are in the way of some of our tumor resections that we literally etch a sketch away. And it has to be, as you can see in that picture there, it literally looks like we're holding a pencil. So that same drill that you saw is incredibly flexible. We can use it for the coarsest of bones, where we're just taking out thick bone like Dr. Judy showed you, or we can use it to etch away the smallest bone, smaller than a human tooth. Next slide, please. Now, we're not going to show you an example of a neurosurgical robot, but suffice it to say we have those as well. What you see in that picture there is literally a robot arm that is holding a device that we can use to put a needle way down deep in the brain to take a biopsy. Now, there are some tumors that we really shouldn't go after openly, if I were to say it that way. There are tumors that are so deep that getting there might cause more damage, and we simply need to find out what they are so we can treat them with things like radiation or chemotherapy or both. And in that case, a needle biopsy is very important. And we traditionally use our navigation to guide a needle biopsy, but what's exciting coming around the corner is there actually are robots being developed that can move into that position to get that needle down to that critical position. Now, it still requires the neurosurgeon drill the hole and pass the needle, but we're getting one step closer to real sort of automation, if you will, of the process. Next slide. And we also have lasers. And I think, Kevin, you might want to talk about that. I know we don't have any examples, but we literally can pass, imagine where I showed you that example of that needle passing into that hole towards the tumor. Well, we can also pass a needle with a laser on the tip into that tumor to burn it from within. Can you switch to the camera so Dr. Judy can talk about that?
So using the navigation device, we exactly identify where the tumor is. Then we drill a hole, a very small hole, 3.2 millimeters. And we line it up with our navigation unit. There's a separate mechanical arm that comes in. It's not robotic, not the one we use, not yet. And then there's a little bolt that we actually screw into the skull. And then we take the laser probe and we can very accurately put it down into the brain. And then the bolt tightens it down and that stays there. Then we take you to the MRI scanner where we hook up this fiber optic cable to the actual laser itself. While you're in the MRI scanner, we're constantly scanning, and we use thermography software, which can detect temperature changes. So that with the laser probe in, we turn it on and we watch how it burns. It actually heats up the tissue and cooks it from inside out. Once temperature hits about 43 degrees centigrade, it really denatures the proteins and destroys the tissue. So this is very effective. It's almost the same as doing a craniotomy to remove the tumor because the tissue is now just dead tissue. It won't come back. The trick is doing the ablation up to the very edge of the tumor with the understanding that we frequently see an area of inflammation at the margin of our ablation. That's kind of like when you microwave food. When you first take it out of the microwave, it feels warm, but if you let it sit for a minute, it continues to heat up. So that over time, this area that's been ablated with the laser will continue, the lesion will continue to expand. So we typically treat up to a few millimeters from the edge and then get an MRI the next day or the day after, and you'll see how the lesion has expanded. So this is a nice way of, again, treating tumors and radiation necrosis if you ever have radiosurgery. Treating this in a minimally invasive fashion. And especially it's good for tumors that are non-operable, that are deep in the brain.
Can you go back to the slide deck? Yeah, so those tumors, like I showed you in that robot example, that are too deep for us to really go after safely. This is a great technology and really something that everyone should have in their armamentarium. So moving on, next slide if you could. We already talked a little bit about some of the instruments that we use when we're operating. And again, I would classify these as micro instruments. But I think it's worthwhile to go over some of the other instruments, whether it's the tip types we use or something called a bipolar. That yellow instrument in the example on the slide is actually two prongs that pass electricity between the tips. And this was invented a long, long time ago, decades and decades ago, but it also was a game changer because it allows us to take the small blood vessels that are constantly oozing from the brain, constantly clouding our view, constantly losing blood, and basically use that electricity to seal them shut, and it dries up the surgery. So can we switch to the examples, and we'll show you some examples of some of the tips we use and some of the bipolars we use and how we would employ them.
All right. So during a surgery, we always strive for what we call perfect hemostasis. We want everything to be dry. We don't want any of these raw edges to be able to bleed after surgery. So we spend a lot of time making sure that we have this very meticulous hemostasis. Our go-to is really this bipolar, which basically emits electricity across the tines in a very precise way. And we can coagulate, even the smallest, tiniest vessels, that are one red blood cell moving through at a time. So we've got all sorts of different sizes. We have different angled ones to work around corners. And this is all part of sort of our micro instrument type array of things. We also have all of these special tools that we use under the microscope or the exoscope or the endoscope, that all sorts of different shapes that have been optimized to do what we need to do. This is our standard micro set. We've got many different instruments, different shapes, hooks, spatulas, round knives. They all have names. I don't know any of them. I just ask for the one that I like. And at a place like Jefferson Hospital for Neuroscience, we've got the world's best health team, and they've operated with us hundreds and hundreds of times. So they all know exactly what we like and how we like to do things. But this is how we can operate in the tiniest of spaces and protect all those critical structures.
All right, can you take us back to the slide deck? And then the next slide would be great. So another tool we use, and we don't have one here, do we?
No.
So we'll just talk about it, but it's important. There are some tumors that are so tough and rubbery, we can't simply grab them or pull them apart piece by piece. We have to pulverize them with sound waves. And if you could hit that button one more time, that little video, it's very quick. You can see the vibrating tip. And basically what that does is pulverize the tumor into small pieces that are then sucked up, if you will, the vacuum hose that surrounds the vibrating tip. That's called an ultrasonic aspirator. Some people call it the Sonopet or the CUSA. Those are just different names. That's a very valuable tool that allows us to get to those tough, rubbery tumors, but it's also a little bit more forgiving of some of the blood vessels that it shows in the video there. And again, one more tool in our toolbox that if we get in there and it's a tough tumor, we say, pull out the Sonopet, pull out the CUSA. We're going to need to go deeper in this one. And we have, just like the drills, we have a lot of different tips. We have long, thin ones, short, fat ones. We can actually use those up the nose when we're doing surgery endoscopically. We can use them through the open microscope or the exoscope. So again, really flexible tools that are adaptable. Can you go next slide, please? And we already showed you a little bit of some of the plates that we use. And we can go into that. I'll just go to the next slide real quickly before we go to that, because we can combine the plates with other technologies. So next, one more advance. There are times when we can't actually put your bone back. So if you've had a bad infection or if the tumor has grown into the bone, we can't put that back in for obvious reasons. So we can actually generate computer-generated prosthetics that exactly fit the bone that's missing and put that back in with these plates and screws. Can you hit that button again? So there's an example on your left of a small one involving the orbit, your eyebrow ridge, and then a massive one involving the whole top of the head that you'd see, for example, in a patient who maybe had a severe trauma or a massive stroke or an infection, and we couldn't put that bone back in. And then, of course, we also have putty. So that thing in the middle, that syringe that sort of looks like it's squeezing out some goo, that's actually like silly putty almost. We can use it to fill little cracks and gaps that are not big enough to justify creating a whole new prosthetic. And of course, all these things we can secure and use in combination with our plates. Can you show the plates now? Just to show some of the array of the different shapes we can use to cover all the defects if we have a gap, because sometimes we're left with more than a gap than we want. And if you could zoom in there, we have round covers and we have little long plates and squares.
Then we also have titanium that we can custom shape. It's kind of stuck. But sheets of titanium that we can custom shape into whatever we need. They're flexible in different thicknesses and different strengths. So we can make pretty creative reconstructions to make sure that inside things are back where they belong, and on the outside you look back like you should.
So I think at this point, we've sort of taken you through from the moment the patient is on the table and the head is clamped into position, through all the tools that we use, to the point that we put the skull back together. And of course, from that point, it's just a matter of stitching up the scalp and putting dressings on and so forth. But I think at this point, would be a good time to talk about questions and field some questions from the audience.
First question that came in is, what surgical method is most used for acoustic neuroma as opposed to the brainstem?
Do you want to zoom out a little bit? Zoom out so we can get us all in. Yeah, just zoom out a little bit. Yeah.
I don't know if they heard the question, but I'll repeat it. I don't know if they can hear his voice. No, I think
We can repeat.
repeat on the microphone.
I asked the question, what surgical method is most used for acoustic neuromas near the brainstem? So acoustic neuromas are these tumors that grow from the hearing and balance nerve, and they grow right from the brainstem, which is a critical deep structure. So what you're trying to do is take out, a big tumor with all of these danger spots around it. As Dr. Lemole said, that Sonopet or the CUSA, that ultrasonic aspirator, is a great tool. where all the critical stuff is around the edges, but none in the center. So we're going to core out the center of that tumor and then meticulously under high magnification, fold that tumor away from the nerves, from the brainstem, checking electrical stimulation and the function of all these nerves. So we can interrogate the nerve with direct stimulation, and then we have our neuromonitoring people actually sending signals from the scalp all the way down into the arms and the legs, so we can check how everything is functioning pretty much continuously throughout the surgery.
And all those tools we talked about, the navigation, whether you use a microscope or an exoscope, they're critical there. That's a small dark hole that you're looking into, and things are very, very, very small. And I don't think we would nowadays do those surgeries without all those tools.
Is there any backup for when the automation fails?
Absolutely. God's computer and these things. I mean, we've been doing surgery long before a lot of this stuff was ever invented. So it's, unfortunately, it does happen sometimes where one of these monitoring mechanisms.
I think just in case you guys didn't hear the question, is there a backup if the automation fails?
And the backup is the surgeon and the surgeon's skills and experience.
I will say that a lot of the surgeons here are trained in what we call the classical techniques. So while we have these techniques to go up your nose or through little holes and things like that, a lot of us trained from the days when we had bigger openings. And so we got very comfortable with the anatomy. So if the little hole approach fails, we convert to the bigger option. And like Dr. Judy said, you use your noggin to figure out where you are.
Well, it's much like flying with instruments in an airplane. You know, if you grew up flying in a plane where you didn't need the instruments or didn't have them, if something fails, you just sort of fall back on your knowledge of how the aircraft's supposed to sound, and using your vision to see how things are going, as opposed to strictly flying by instruments alone or by radar alone. And so it's like that. It's a good adjunct, but you need to understand the basic anatomy and basic techniques in order to see things through, because it's not always perfect. But they're adjuncts to help us do our job more efficiently.
What's done at the surgical site in preparation for your craniotomy?
Yes.
I'm going to repeat the question though.
So what is done at the surgical site to prepare for a craniotomy? So, it's a lot of people think when you come into the room, surgery starts. There can be hours of preparation to do this. So, first thing is patient comes in, our anesthesiology team will usually place a breathing tube. Most of our surgeries require that. They'll get the patient in a situation where we are prepared for any sort of thing that can happen during surgery. The next steps will be to position the patient, and we talked a little bit about the head holders, and that's where we're using all of those. People ask, how long did it take to be a brain surgeon? So it's 4 years of medical school, 7 years of training in a residency, 20 hours a week, a year of fellowship for most of us. And that's so that we can visualize what is going to happen in surgery and make sure it goes smoothly. Then what we're going to do is we'll plan what we're going to do. We'll use the image guidance as our backup to help us. In the past, we would all, and I think we all did this, we would take a clipper and we would shave a whole half of the brain, the whole half of the skull. We would not have a single nick or a single drop of blood. These days, we try not to shave any hair, or if we do, just the tiniest strip. I always say everybody is a little vain, us included. We want to look good coming out of this. We want you to look good, so we take time to do that. And then we'll actually start the operation. So it could be an hour and a half, 2 hours before the patient's family actually gets that call telling them surgery started.
And not to mention very sterile prep and drape, and prepping the skin and soap and betadine, et cetera, and making sure everything's very, very sterile, and then a lot of sterile drapes to keep the field completely clean. There's a lot of effort into sterility, and
that's why the patient comes out looking orange all over.
So you may notice behind us this table is covered with these blue drape, these blue towels and things. Blue is like the color in the operating room. Anything that's blue is sterile. You can't touch it unless you've been scrubbed. And likewise, we make the scalp as sterile as possible to eliminate any bacteria.
Question.
Is there enough collateral circulation to compensate for catheterized vessels?
Cauterized? Yeah, go ahead.
Cauterized? Oh, yes. So cauterized, did you say? So the question was, is there enough collateral circulation to address cauterized vessels, those vessels that we squeeze together in the bipolar and we close? And the answer is yes, sometimes, and no, sometimes. In fact, that's part of what we do. A lot of times as we're working on a tumor, we have to figure out which branches of the vessels go into the tumor. So it doesn't matter if we cauterize those. In fact, we want that tumor to be starved and die. But the tumor, the vessels that are just passing by the tumor and going on to feed the brain downstream, it's critically important that we preserve those. So that's part of that 7 years of training to figure out which vessels are which. It is not always the case that there is adequate collateral.
And if you don't know if you can take it, you don't
Don't
take
take
it.
it.
What is the average recovery time?
Oh. So we usually knee jerk. The question was, what's the average recovery time? I assume we're going to talk about after a craniotomy. So by knee jerk, we usually tell people 4 to 6 weeks or so to recover. That might be a couple of days or so, maybe in an ICU setting, maybe a day or overnight in an ICU setting after a craniotomy. And then maybe 2 or 3 days on a regular hospital floor while you get mobilized and get back to eating and drinking and usual activities. And it gets shorter and shorter over time. But for an average craniotomy, we'll tell people 4 to 6 weeks or so while their wound is healing and they're starting to pick up their activities. And certainly that's not all in the hospital, but there's some time for healing. When you look at recovery from some of the minimally invasive surgeries like endoscopic pituitary surgery, patients usually go home the next day. It might be in a matter of 12 or less than 24 hours for sure. And they can be back on their feet, in a day or so. And they might only need the first week or two while the nose may be a bit stuffy or while they're recovering, but they get back much more quickly. So less invasive, I think the less healing time.
I do like to blame anesthesia though for that 4 to 6 weeks. Because it's funny, after about a couple days, the patients aren't typically complaining of the incisions. It's I'm tired, I'm groggy, I'm foggy. So I'm more than happy to blame anesthesia for that. But it's a stress on the body, and it does take a couple weeks to fully recover from that.
Are the patients always under anesthesia for a procedure?
Okay.
Are the patients always under anesthesia for a procedure? The quick answer to that is yes, but there are many forms of anesthesia. Typically, we use general anesthesia where you're completely out, but there are times where we do what's called awake anesthesia, where the patient's heavily sedated. As I like to tell my patients, we give you 5 martinis, then we numb you up with long-acting Novocaine, we open the skull, and then we wake you up so that we can map out your language areas and have you talking to us. So that's called awake anesthesia. There are some times where we just do it under local anesthesia with a little sedation, so you're wide awake, and those are the more minor procedures. But in general, most of our patients are done under general anesthesia, where they're completely out, or awake anesthesia, where they're sedated with a fast-acting sedative, and then we use a long-acting form of Novocaine called bupivacaine, and that really keeps the scalp numb. The brain itself has no sensation. So you can operate on a brain and the patient never feels it. It's the scalp and the covering of the brain, the dura, that have sensation. And those we block with the Novocaine.
Is there a risk of deficit post-op?
So the question is there a risk of deficits post-op? There is no surgery that any surgeon performs that doesn't carry risk. And I, we always say you should never enter any surgery lightly. I don't think there's ever been a patient that came to myself or any other brain tumor neurosurgeon who wanted to be in that room. Each tumor, each surgery carries its own risks. Some of those risks are the location. Is it in a critical location? There are some parts of the brain that are more forgiving. That we always, the right frontal, it's a happy day if we're operating in the right frontal lobe, because that's very forgiving. The left temporal lobe, where speech is, that's a much more challenging day. That's where we might do it awake. But each case will have its own risks depending on where it's located. Some tumors can be huge, but everything's pushed to the side. Some tumors can be small, but all the critical structures like nerves and arteries are running right through it. So each case will have specific risks, and the surgeon will talk to you about those. Oftentimes I'll say, here are the things that are in play around this tumor. This is what can happen if any of those are injured. This is what I expect to happen. And I would say most of our surgeries go extremely smoothly. Unfortunately, not all of them, but most of them go, and that's why people come to a place like Jefferson for the experience, the expertise, the team, and the judgment. And we can keep those risks minimized. Sometimes that means we have to leave those vessels behind because it's too stuck. And then we know that 1 more millimeter that's where all the risk came in. So it's that judgment, it's all of these tools, and nothing really substitutes for technique, judgment, experience.
And just for clarification, because I'm not sure everyone knows, the brain is truly organized with different components. There's a part of the brain that controls your muscles on the other side. There's a part of the brain that controls your speech area, your ability to put out words versus understand words. And these are all different localizations. So that's why Dr. Farrell was talking about, we can know even before the case what's on the table at risk.
And sometimes we can do things, special MRIs, things like functional MRIs, where you can be on an MRI talking and we can see what areas light up. And that will tell us how risky this area really is. And it may be that we're perfectly safe and the risk has gone way down, or the risk is too much that we have to do a less invasive or a biopsy alone.
Explain CyberKnife and is the radiation dangerous for the providers?
Is radiation?
Dangerous for providers.
So the question was, can we explain CyberKnife, which is a form of radiation delivery, and is the radiation dangerous to the providers? So basically, CyberKnife is a form of stereotactic radiation. Stereotactic means very highly focused or conformal way of delivering radiation. There's various forms of that. Most are by photon. It's a way of generating energy. Others are by proton beam or proton, which is a very large or heavy particle of radiation. There's different ways of delivering this, whether it's by CyberKnife, by some other form of linear accelerator like a Novalis device, by a gamma knife, which is more of at least traditionally a static device. Different ways of putting beams into one area, all focused on one point. And whether the device moves around you, which is how a CyberKnife or a linear accelerator may work, or whether it's more of a static thing, these are just very focused areas, ways of delivering radiation to a specific pinpoint and avoiding critical structures, but treating the tumor. It's not dangerous to providers. This is all shielded very carefully, even for the patient for that matter. So really what's exposed is just that area of the tumor. And we deliver it for the patient standpoint, by various beams of energy that'll go in and be additive, almost like you might use a magnifying glass to start a fire, but it's not that form of energy, but it can focus on one area. You can pass your hand through the magnifying glass where it's not focused and it doesn't hurt. It's a very similar kind of thing. We use these various beams from different angles that'll really just focus the energy on the tumor, what we need to treat. It's not that dangerous for the other structures around it, for the rest of the patient that's in the device being treated, or for us as practitioners that might be around the outside of the device or nearby. It's all very, very shielded. So that's kind of the concept of stereotactic radiation.
Discuss sunken flap syndrome.
Me.
All right, can we discuss sunken flap syndrome? So sunken flap is, as we've showed you on this craniotomy, when we bolt it back in place, you can see that the bone flap is sitting right in the same plane as the rest of the skull. What happens sometimes, depending on how the bone flap is secured, it can sink down. And so now you have this ridge here with the bone flap sitting below it. That is all determined by how the bone flap is secured to the skull at the end of the operation. It was more common years ago when we used sutures or wires. With the titanium plates, now we don't see it as often because the titanium plates are very rigid and strong, and they tend not to allow the bone flap to shift. But it's just the bone flap gets pushed down below the level of the skull.
And there's another example of where they'd have, so if someone has had an operation, for example, on this model, and we have to leave the bone out. So remember I said it might be an infected bone or a tumor infested bone, or someone with a massive stroke and we have to leave the bone out to relax the brain. Well, they're not going to get a bone or even a prosthetic put back for about 3 months. And in the meantime, their brain will swell and then start to relax. And when it when it relaxes, it actually starts to sink in. And if you look at someone, they literally have a concavity, a sunken, almost like a bowl on their head. The brain does not like that. It slows people's recovery. And so as soon as that brain is relaxed, usually about 2 or 3 months after that kind of massive operation, we like to put the bone back or a prosthetic back because the brain wants to be closed up again. And people will actually see an acceleration in their recovery when we put that bone back. I think maybe one more or no?
Can you explain the timeout process?
You,
Come on over.
this is one
Here
of
we go.
our,
We have our experts. Kelsey's one of our OR nurses. And she's going to explain the timeout. The question is, can we explain the timeout process?
So the timeout process is something we do at the beginning of every case. The whole team is involved, the nurses in the room, the scrubs, surgeons, anesthesia. We make sure we have the right patient, right surgery that we're doing, the right laterality. Just make sure that everybody's on board, any risks that, we are anticipating, that everybody in the room is ready to start the procedure. Yeah.
and thanks. And this is all modeled. Everything is about safety. As Dr. Evans talked about the cyber knife and how do you make sure it's safe? There are huge teams involved in everything we do. There are multiple safety checks. We've modeled a lot of what we do in medicine after the airline industry. I don't know if that's good or bad, but this is what they would do before every flight. So we have this, and it's to open the lines of communication. So everyone in the room is on the same page. And we've discussed the risks. We know we're on the right side. We look at the imaging, and we do that as an entire team every single time.
And that team part, I think, can't be emphasized enough. We're talking to you as surgeons, and that's who you're used to seeing coming out talking after the case and before. But what you don't realize, there are at least 5 or 10 people that are supporting us, whether it be someone circulating in the OR, getting the tools we need, our scrub assistant handing us the tools, could be a resident or a fellow assisting us in the operation as well, anesthesiologists, all the transport people, all the imaging people who got those x-rays in advance, all the people who service these tools that we use. The list goes on. So although we sort of unfairly bask in the glory, it really is a team approach. Medicine and surgery is a team sport.
And at the end of each procedure, we also do a debriefing. We go over everything from instrument counts to cottonoid patty counts, make sure everything's in order and accounted for. And we'll also go over the procedure itself and how did things go? Any pitfalls, any issues that we need to be mindful of even post-operatively. So this is a way of timing into the surgery, a way of kind of going out of the surgery as well. So it's all very regulated.
And probably the most important part of this is that anyone can shut down the system if there's a problem. The nurses can, the scrub techs can, the anesthesiologist can, the surgeon can. So if there is a discrepancy, boom, everything comes to a halt until we figure it out. And everyone is allowed to do that.
It's like launching into space. We want all green lights before you go. You don't want a yellow on the board anywhere.
Right. Well, I think that concludes our webinar, and I want to thank everyone for tuning in. And again, I want to honor those patients that we've served, their families, their caregivers, and of course, the doctors and the whole team that we mentioned that make these kind of surgeries possible so that people can be healed or move on to the next phase of their care. So thank you, everyone, for tuning in. Appreciation from all of us.
Thank you.
Good night.